Welcome to the deep dive. You know, if you or someone you care about has gone through cancer treatment, well, you understand it's just an incredibly tough journey. And often one of the biggest hurdles, really, is that awful nausea and vomiting that can come with chemotherapy. You can just completely drain someone. But, and this is the encouraging part, there's actually this whole sophisticated world of therapies out there designed specifically to fight this, to make things more manageable. So today we're diving deep into exactly that, the landscape of these anti-nausea drugs, the antiemetics. Our source material for this exploration gives us a really detailed look at the different types of drugs used to prevent and manage CINV. That's chemotherapy-induced nausea and vomiting. We've got some really compelling stuff to unpack here.
Yeah, absolutely. And our goal today isn't just to list off drug names. We want to really get into how they work, their mechanisms, and crucially, how they interact with other drugs. That's vital stuff. Plus, who they're best suited for, patient considerations, and of course, potential side effects or adverse events. Getting into these details, it's not just for the doctors and nurses. Understanding this really gives you critical insights into modern cancer care.
Exactly. We're hoping for those kinds of aha moments, taking this complex medical info and making it, well, easier to grasp, something memorable. So if you've ever wondered, how do these medicines actually work, or why is this drug chosen over that one, then you're definitely in the right place. Okay, let's get into it. Let's start with a class of drugs that have been, well, pretty significant game changers,
Yeah.
the NK1 receptor antagonists. Our sources highlight a couple here, fosaprepitant and rolapitant. What's interesting with fosaprepitant is the dosing, just a single IV dose, 150 milligrams on day one. But setting aside the dosing for a sec, how do these actually work? What are they doing inside the body?
Right, so their mechanism is really quite precise. Fosaprepitant and rolapitant are what we call substance PNT1 receptor antagonists. Think of substance P as like a messenger chemical your body releases. It binds to these specific spots, the NK1 receptors in your brain, your gut, and that binding triggers nausea and vomiting. So what these drugs do is they basically block those receptor spots. They occupy them so substance P can't latch on and deliver its get sick message. It prevents that whole cascade. And rolapitant specifically, it's really noted for preventing delayed nausea and vomiting. That's usually given as a single pill, 180 milligrams, also on day one.
Okay, so they're like shutting down the communication line for nausea. Makes sense. And it's not just what they do, right? It's also about how they interact with other things, other meds, or body systems. The sources mention that all these NK1 drugs are mainly broken down or metabolized by these liver enzymes, the cytochrome P450 group, specifically one called CYP3A4. Aprepitant and fosaprepitant also use a couple of others slightly, CYP1A2 and CYP2C19.
For people listening, why is knowing about this breakdown pathway, this CYP3A4 thing, so important? What does that mean for drug interactions?
Oh, it's absolutely critical. It directly explained a major interaction, especially with dexamethasone. Dexamethasone is another cornerstone drug used alongside chemo. Because fosaprepitant and aprepitant inhibit that CYP3A4 enzyme, they slow down how the body breaks down dexamethasone. This means you end up with more dexamethasone floating around. So if the dexamethasone is given as a pill orally, its dose usually needs to be cut back by about 40% on the second or third day. But here's a really interesting detail. This dose change isn't needed if the dexamethasone is given intravenously through an IV. Why is that? Why the difference between pill and IV?
It's because when you take a pill, it goes through the liver first before hitting your main bloodstream. That's called first pass metabolism. A lot can get broken down right there. With an IV, you bypass that initial liver pass, so the enzyme inhibition doesn't affect it in the same way right away. And what's quite unique about rolapitant, the other NK1 drug we mentioned, is that it doesn't inhibit dexamethasone metabolism, so no dose adjustment needed there, which can be a real advantage sometimes.
Ah, okay. That's a big difference for rolapitant. Definitely simplifies things if a patient is also on dexamethasone. Beyond dexamethasone, are there other interactions with these NK1 drugs that people should be aware of? Anything else significant?
Yes, a couple of others stand out. First, for women who could become pregnant, aprepitant and fosaprepitant might make oral contraceptives, birth control pills, less effective. So using another form of contraception is generally recommended. Second, for patients taking warfarin, which is a common blood thinner, aprepitant or fosaprepitant can actually decrease their INR level.
INR. That's the measure of blood clotting time, right?
Exactly. A lower INR means the blood clots more easily, which could be risky. So their INR level needs to be checked carefully about 7 to 10 days after they get the antianic.
Wow, okay, that's really important safety information. And wasn't there also a specific warning for certain patients, something about nerve issues?
Yes, that's right. Caution is advised when using NK1s in patients with lymphoma. Some studies suggest that neuropathy, that's nerve damage causing pain, numbness, weakness, seems to be more common in lymphoma patients getting a Prepotent as part of a chemo regimen called RCHOP.
RCHOP. Okay, that's a common lymphoma treatment.
Right. And it's thought to be linked back to that CYP3A4 inhibition by a Prepotent. Since the other NK1s also inhibit CYP3A4, similar caution, well, it probably applies to them too. As for just general side effects with fosaprepitant, people might experience things like asthenia, just feeling weak, dizziness, and hiccups. Hiccups are actually quite common. Rolapitant has also been linked to things like loss of appetite, maybe neutropenia, which is low white blood cells, and again, hiccups.
Hiccups. Interesting. So,
Right.
okay, given these complexities, the interactions, the specific cautions with the single NK1 drugs, it makes sense that they develop combinations. Our sources talk about fixed combos like nitupetant combined with polonosetron and
Hmm.
also fosnitupetant with polonosetron. How do these dual-action meds work together?
Well, it's a smart approach. They leverage two different but complementary ways to stop nausea, so you get broader protection. They include nitupetant or fosnitupetant. Those are the NK1 blockers we just discussed, stopping substance P. And they combine it with polonosetron, which belongs to a different class, the serotonin 3 or 5-HT3 receptor
The
antagonist.
vector path.
Exactly. Serotonin 3 receptors are another key pathway involved in nausea, especially that really acute, immediate nausea right after chemo. So the polonosetron part mainly tackles that immediate nausea, while the NK1 part, the nitupetant or fosnitupetant, is good for both the acute and the delayed nausea that can come later. It's like a tag team approach for more complete coverage.
Got it, like building a stronger wall using two different types of bricks.
Hmm.
So what about dosing for these combos? And are there any specific patient groups where we need to be careful?
Yep. The oral version, nitupetant polonosetron, is just one capsule. It has 300 milligrams of nitupetant and 0.5 milligrams of polonosetron, taken just once on day one of chemo. Then there's the IV option, fosnitupetant polonosetron. That's also given once on day one, 235 milligrams of fosnitupetant and 0.25 milligrams of polonosetron. In terms of who needs caution, definitely patients with liver problems, hepatic dysfunction, or severe kidney impairment, including those on dialysis. Their bodies might not process the drugs normally. Common side effects people might experience are things like headache, maybe some weakness again, indigestion, feeling tired, constipation, and sometimes skin redness called erythema.
All right. So we've talked about these newer, quite targeted therapies. Let's shift gears a bit and look at some of the maybe foundational drugs, the ones that have been used for a longer time against CINV. Let's discuss benzamide analogs. Metoclopramide is probably the best known example here. How does this older drug work? It's still used, right?
Oh, yeah, definitely still relevant. Metoclopramide is interesting because it kind of hits multiple targets. It's not as specific as the NK1s. Its main action is blocking dopamine receptors in a brain area called the chemoreceptor trigger zone, or CTZ. That's sort of like the brain's vomit control center. But it also stimulates something called cholinergic activity in the gut. Basically, it boosts a chemical messenger, acetylcholine, which helps move food through the digestive system faster, increases gut motility. And on top of that, it also blocks some serotonin receptors, but peripheral ones out in the intestines. All these effects tend to be stronger at higher doses.
Huh. So it really is doing a few different things, brain, gut. What about side effects? And how is it typically dosed now? I feel like I've heard about issues with it.
You're right. Historically, they used much higher doses of metoclopramide to get good anti-nausea effects, sometimes like 1 to 2 milligrams per kilogram IV. Pretty high. But now, the guidelines generally recommend lower doses, maybe 10 to 20 milligrams every 6 hours, usually just on an as-needed basis. And that's largely due to side effect concerns. Patients might feel mildly sedated or get diarrhea. But the bigger concern, especially with higher doses or using it for a long time, is extrapyramidal reactions, or EPS.
EPS. Okay, what does that actually look like?
It refers to involuntary movement problems, things like dystonia, where muscles contract uncontrollably, causing twisting or odd postures, or akathisia, which is this awful inner restlessness, feeling like you just cannot sit still. These can be really quite distressing for patients. The good news is they can often be treated or prevented by giving other medications like diphenhydramine or benzotropine alongside it.
Right, important to know there are ways to manage those potential neurological effects. Okay, lastly, let's briefly touch on another older class, the phenothiazines. This includes drugs like prochlorperazine, chlorpromazine, maybe promethazine. What's their main way of working, and what are the key side effects people should know about?
Yeah, the phenothiazines. They primarily work by blocking dopamine receptors, again, in that same chemoreceptor trigger zone in the brain, similar to one of metoclopramide's actions. However, their side effect profile is often what limits them or guides their use. They can cause pretty significant drowsiness, like really knock people out sometimes. Also, hypotension, a drop in blood pressure, and those same extrapyramidal reactions we just talked about, akathisia and dystonia, can happen with phenothiazines too. So that sedation potential is a big one to watch out for. While they've been around a long time and can be effective, these side effects often mean they're used maybe when other drugs haven't worked or in specific situations, maybe more for breakthrough symptoms.
It's really incredible just how many layers there are to this, figuring out the best way to manage these side effects. We've covered quite a bit today. We explored this whole sophisticated world of anti-nausea therapies, from those newer NK1 receptor antagonists and their combination forms, real steps forward all the way to the older workhorses like the benzamides, metoclopramides, and the phenothiazines. It's really clear that each drug class has its own distinct way of working, its own benefits, and yeah, its own challenges in this fight against CINV.
Absolutely. And this brings up a crucial point, doesn't it? What's so important is understanding not just what a drug does, but how it interacts. How it interacts with the body, with other medications the patient might be taking. We saw clear examples, right? Like how those liver enzymes, CYP3A4, affect NK1 agents and their interaction with dexamethasone, or needing dose adjustments for oral dexamethasone specifically, or even those very specific cautions thinking about lymphoma patients on RCHOP, or people with significant liver or kidney issues. These details, they're not minor. They are absolutely critical for making treatment both effective and safe. It's about refining that care. This really raises an important question.
Right, and that's exactly why going through this detail helps you, the listener, understand things better. You get a more nuanced picture of why maybe one drug is picked over another, what challenges might pop up, and really how this comprehensive personalized care actually works to try and ease suffering during a really tough time. It puts precision medicine into, well, perspective.
Yeah, exactly. And what's truly fascinating here, I think, is seeing how the precision of pharmacology, I mean, getting down to the level of enzyme interactions, specific dosage tweaks, how all that plays such a direct, vital role in making patients feel better, in improving their quality of life when they're facing these huge challenges. It just really underscores the continuous evolution, the meticulous care that goes into modern medicine, always trying to get that optimal relief with the fewest possible problems.